Extract 1, questions 1 to 12. You hear an obstetrician talking to a patient called Melissa Gordon. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So this first meeting, Mrs. Gordon, is mainly a chance for you and I to get to know each other. I'll ask about your medical history, and this is also an opportunity for you to ask me any questions that you've got at this point.
Sure.
So some background. What kind of work do you do?
I have a job at an engineering company. I'm a computer programmer. I currently do 4 days a week, but I hope to reduce that to 3 after my maternity leave.
Ah, excellent. So tell me about your medical health. Do you have any conditions I should know about?
Well, I have asthma attacks, but they don't happen often. I lost about 10 kilos, and that certainly helped. I have an inhaler, but I hardly ever use it. Oh, I should also let you know that I come out in terrible hives if I take penicillin, but not other things. I'm fine if I eat nuts, for example. I have a fairly healthy lifestyle. I'm a vegetarian and I've never smoked.
Good.
I'm afraid I don't go to the gym or anything, but I walk to work and generally keep active.
Oh, that's good. So this is your first pregnancy?
No, I have a daughter called Ella. She's 3 now.
Ah, and did everything go smoothly that time?
There were no major problems during the pregnancy itself, but it took me quite a time to fall pregnant the first time. After having various tests, I was given some fertility drugs. Oh, what were they called? It's on the tip of my tongue. Never mind, it'll come back to me. This time, though, I didn't need any help.
Oh, it's no problem. What about labour last time round?
Oh, that was a nightmare. Though everything, thank goodness, worked out in the end. It was a breech birth. It looked as if I might have to have a caesarean, and I really didn't want that. I was pleased I managed without an epidural, too. They had to use forceps to get Ella out, but I didn't need any stitches, so that was okay. Unfortunately, though, I had some difficulties after the birth too. I was desperate to start breastfeeding, but that didn't work out. At least not until I was given some guidance by the midwife.
OK. So can I ask you about the baby's father?
Sure. That's my husband, Paul. There's something in his family history that I should tell you about, I think. His grandfather and father both had epilepsy, though he hasn't developed it himself. I'm not sure if that means his children have a greater chance of having it or not. Oh, also, he has a child from his first marriage, and she has Down syndrome, so he gets a bit anxious when I'm pregnant.
Oh, well, that's understandable, of course. We can discuss various testing options if you like. You might want to consider amniocentesis, for example.
But that carries a risk of miscarriage, doesn't it? I don't want to go for that. I've heard about another test called CVS. Is that something to consider?
Well, it's certainly an option. However, that procedure, in fact, also carries a small increase in the risk of miscarriage. And you'd need to come to a decision fairly soon, because it's normally carried out between weeks 10 and 12 of the pregnancy.
Well, I can tell you straight away that if there's more risk, then I wouldn't consider it. I know my husband will feel the same.
Well, that's fair enough. So, is there anything else you'd like to ask me about today?
Nothing urgent. But it'd be good to know more about how to get siblings ready for a new addition to the family. I want to make sure Ella doesn't feel threatened or replaced or anything.
Well, there's a leaflet that many parents find helpful. Here we are. Have a look through that.
Oh, thanks, that's great. I'm sure I'll have lots more questions at our next meeting.
Extract 2, questions 13 to 24. You hear a gastroenterologist talking to a patient called Toby Smithers. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Mr. Smithers?
That's right, Toby Smithers.
Now, I think you've been having some stomach problems.
Yes, that's right, for some time actually.
OK, I've got some notes here, but perhaps you can tell me in your own words about those problems. About any treatment you've been having, or anything else you can remember that seems relevant.
OK. It all started about 9 months ago with a stomach upset.
OK.
I thought I'd caught the vomiting bug that was going round.
Yes.
Basically, I just couldn't keep anything down. No diarrhea or anything, but it was pretty bad.
Right.
Anyway, it cleared up in a couple of days, and I went back to eating normally. The thing was, though, from that time on, whenever I had a meal, lunch or dinner, I'd feel incredibly sleepy almost before I'd finished, and for about half an hour afterwards. I didn't feel tired as such, not in the sense of fatigue. It's just that I could hardly keep my eyes open.
I see. Were you in any pain?
No, none at all. The only other symptom was that I was getting very thirsty, especially at night, so I was drinking a lot.
Right.
So I went to see the doctor, expecting some simple explanation, but she said my symptoms were quite unusual. Well, not the drinking. She explained that the stomach upset had left me dehydrated.
Yes, that's right.
But it didn't explain my other main symptom.
And the dehydration passed?
Yeah, that was just a temporary thing. Then she asked me if I'd ever had stomach cancer, which was a bit worrying.
But you haven't?
No. But then she explained that there's a condition that has similar symptoms to those I had. She didn't think I actually had that condition because it generally affects people who've had stomach surgery, and I hadn't. It's called gastric dumping syndrome.
Oh, yes.
Anyway, what she suggested as, like an interim measure, was following the treatment plan for that syndrome, even though I probably hadn't got it. So I had to keep drinking because I needed to keep my fluid levels up.
Yes.
But not whilst I was eating. So in other words, I had to separate the two activities by about half an hour. Then as for the meals themselves, she suggested an eating regime that she called little and often. So, no major blowouts and no skipping meals either.
Sure. Did that help?
Yeah, it did, but it was only meant to help me in the short term. Because meanwhile, I had various tests. I gave a urine sample, went for a blood test, neither of which showed up anything untoward. So I just hoped it'd clear up of its own accord.
But it didn't.
Well, no. The regime worked all right, but as soon as I went back to eating and drinking normally, the symptoms would come back.
OK.
So the doctor referred me for an endoscopy. I saw a gastroenterologist for that. He'd looked at my other test results and examined me and everything.
Sure.
And of course, once the results of that came back, they showed that I'd got Helicobacter pylori.
I see.
So I went on the course of treatment, the 3 drugs for 2 weeks,
Yes.
2 different antibiotics and an antacid. That's the combination which gets rid of it.
Yes.
After that, I went back for a breath test, and that was all clear. So I thought that'd be the end of it, and I'd be back to normal.
But you're not.
Well, I've given it a couple of months, but the symptoms are the same.
OK.
If I stick to the eating regime, I'm okay. When I come off it, I'm back to square one. So I'm thinking, sure, the stomach problem that the gastroenterologist found has been dealt with, but that wasn't what was causing the original problem.
And how's this affecting your everyday life?
I can live with it. Obviously, it would be different if I was driving for a living or operating machinery, but I'm a teacher, so it's okay. But to cut a long story short, I asked for a second opinion, and so here I am.
Part B, questions 25 to 30. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. Now look at question 25. Now, read the question.
The new draft recommendations make 3 points. The first point is that WHO recommends a reduced intake of free sugars throughout the life course. The second recommendation is that the intake of free sugars in both adults and children should not exceed 10% of total energy intake. But we also make a third recommendation, and that is that a further reduction to less than 5% of total energy gives additional health benefits. We know that dietary risk factors are very important factors for the risk of non-communicable disease. We have an epidemic of non-communicable diseases. We have at the moment 36 million people dying from non-communicable diseases, most of them in the developing world, 80%. We have a projection of 50 million for 2030, so it's huge. And dietary risk factors, as well as tobacco, are one of the main determinants of those diseases. I mean, if you remove the risk factors, then a lot of those deaths can be preventable.
Question 26. Now, read the question.
Overall, what we found were some very reassuring things for physicians caring for women with epilepsy and for women with epilepsy who are planning to become pregnant. Because what we found is counter to previous dogma, I think, women with epilepsy are not at a substantially increased risk of having to have a C-section during their delivery, late pregnancy bleeding, or premature contractions or delivery. Also, the findings strongly support that if a woman is seizure-free for a period of time, 9 months to 1 year, prior to becoming pregnant, it's very likely that she will continue to remain seizure-free throughout the pregnancy. So this is very reassuring information to women and their physicians as they plan going ahead with pregnancy.
Question 27. Now read the question.
Opioids like codeine have very limited evidence in the management of chronic persistent pain. I think our role in the pharmacy is to have the conversation with patients, to help them understand the biopsychosocial model of chronic pain and to shift their expectations towards improving their function rather than expecting a cure of their pain. We also need to refer these patients to a GP for a comprehensive assessment.
Annoyed customer. This will take more time out of our busy schedules and more money out of our pockets on pain relief, thanks to those who abuse it.
It's important to help consumers understand that codeine is a highly addictive drug. We know that tolerance, dependence and addiction to codeine can develop very quickly, and that many people are self-diagnosing and self-treating with codeine combination products available over the counter. I think it's important that we can reassure patients that there are alternatives available in the pharmacy, and that if they do need codeine-containing products, that they can still get them on prescription from their GP.
Question 28. Now read the question.
The aged care channel for me takes a lot of the pressure off having to research, find out information. The staff are accepting of it, so it's just another tool, another resource that we use very often, and I'd have to say they embrace it because it's something they can go and do on their own, but it's also something we can do as a group. The aged care channel is pivotal in our training and development resources. It's something that we use all the time. It's part of induction, it's part of ongoing education, it helps registered nurses with their ongoing professional learning. We couldn't do without it. The aged care channel is a great part of our training and development resource. It's the biggest part. We certainly have libraries, lending libraries in each facility. As I said, it's part of the induction progress, so it's pivotal. We couldn't do without it. The channel to me is a different tool. We don't have the equipment or the skills to make DVDs or live television, so it brings another type of learning, because everyone learns differently, right into rooms right across the villages. So for us it's a different method, and a lot of the staff really respond to that rather than someone just talking at them. So the interaction, the acting, the scenario all adds to the learning.
Question 29. Now read the question.
The idea here is to take those cells out of her body or patients' bodies and reprogram them. That's the term for gene editing. Reprogram those cells to identify cancer, put them back into the body in much larger quantities so that the army has expanded, and then see if that can fight the cancer. It's been an early story over the last couple of years, but the early results are quite promising in leukemia and lymphoma. We've seen a couple of years ago in melanoma, and studies are now getting started in other cancers like ovarian cancer, breast cancer, pancreatic cancer. Very exciting story. We, at our center in Nashville, just 6 days ago, opened a trial in the community for patients with lymphoma. So very exciting time. Well, we've always known that there's a genetic link to a number of cancers. The big struggle is identifying whether a particular genetic abnormality in an individual, say at an early point in their life, is going to lead to the development of cancer. So we know for several cancers there's a high risk with certain genes. I guess the one that has caught a lot of attention over the last several years has been what's called the BRCA or BRCA genetic alterations that lead to an increased risk for breast cancer and ovarian cancer. So understanding more correlations like that, if you have this genetic abnormality at birth or later in life, is that going to lead to the development of cancer? A lot of work still in that area. We're learning it's a combination of those genetic risks and probably environmental risks as well. So it may not just be one thing that leads to the development of cancer for the majority of people.
Question 30. Now read the question.
Right, so Mrs. Smith is a 68-year-old lady. She was admitted 3 days ago with an exacerbation of the COPD. She had a 4-day history of increasing shortness of breath on exertion, not relieved by her puffers. She has no comorbidities and no infection control precautions. She stopped smoking after her first admission about 2 years ago, and she lives at home alone with support from her daughter. She's on IV antibiotics, bronchodilators and steroids, and she's on 2 litres oxygen via her nasal prongs. She has autocalling criteria for oxygen saturations. The target range is 88 to 92% because she retains CO2. Mrs. Smith's other vital signs are between the flags, and she needs QID obs and had some spirometry done yesterday, which the team are going to review today. She reports having a fall at home about a month ago, but she's otherwise independent with her ADLs. Falls risk was low, but I used the override option to make her a high falls risk because of her recent falls history. She's been assessed by the physio and she's on a rollator frame for it to ambulate. Waterloo score is 10 and her skin integrity is intact, and she's responded well to all treatment and she's on a normal diet.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best, according to what you hear. Complete your answers as you listen. Now look at extract.
I wrote a prescription for antibiotics. I did want to talk to you, though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home, so I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so it's just, that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right. Yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now, I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you're able to stop. But
yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
Yes. Yeah.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's on your to-do list. It's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you, and sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure. It feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
Questions 37 to 42. You will hear a plastic surgeon called Norma Woolston giving a presentation about surgical treatment for a condition called Dupuytren's contracture. You now have 90 seconds to read questions 37 to 42. My name's Norma Woolston, and I'm talking today about surgery for a condition called Dupuytren's contracture, with a particular reference to a case I treated recently. Dupuytren was first described by a French physician of that name in 1834. It's a condition in which one finger becomes increasingly bent in a flexed position. The first sign is a formation of small hard nodules in the palm of the hand, but early diagnosis is relatively unusual because there is no associated discomfort. In its early stages, the condition may respond to steroid injections and physical therapy, but this doesn't necessarily halt its progression. The affected finger often becomes increasingly bent and can no longer be straightened. But patients tend to present with the condition only when manual dexterity is compromised, by which time surgical intervention is indicated. My patient, let's call him Eric, presented with quite an advanced case of Dupuytren's affecting the little finger of his right hand, a relatively common site for the condition, although a physical examination revealed that he was also developing the first signs in the thumb on the same hand. Eric was then a 61-year-old office worker who used a keyboard regularly. There isn't very much published so far on the causes of the condition or what might exacerbate the symptoms, but the digital age doesn't appear to have resulted in an exponential rise in the number of cases reported. Eric was finding the condition inconvenient and uncomfortable rather than painful. It was becoming tricky shaking hands with people, and holding a pencil was becoming a challenge. Eric didn't recall any family history of Dupuytren's. That's not unusual, but doesn't in itself mean that there was none. Indeed, we know that the condition is often present across the generations of one family. But because patients don't typically develop symptoms until late middle age or later, it often goes undiagnosed or doesn't develop to the point where it requires treatment. Indeed, mild symptoms are often attributed to mild arthritis or the general effects of aging and wear and tear. Nor did Eric report any of the other associated risk factors, such as smoking, diabetes, or low body mass index. It's worth noting, however, that he was of classic Northern European appearance, tall and fair-skinned, and Dupuytren's is known to be much more common amongst Northern Europeans than in other populations. In Eric's case, the condition had progressed to the point where surgery was indicated. It was clear to me that what was required was a fasciotomy to straighten the finger. Eric had some misgivings about this, as he'd heard about less invasive treatment options. But I explained to him that, taking into account the extent of development of the diseased tissue and the specific site, this was the only option, and he agreed to go ahead with the procedure. Fortunately, Eric was generally in good health, was taking no medications for other conditions, and had no concerns or negative history relating to general anaesthetic. This was much the preferred option because, although the surgery isn't lengthy, usually between 30 and 40 minutes, it does call for a complete immobilization of the hand. After the procedure, Eric was using a sling and pillows at night to hold the wound site high up and so prevent a build-up of fluids. I'd explained that wearing a sling when out and about also provides a degree of general protection. It's a remarkably effective way of signalling to other people to keep their distance, as the hand is very sensitive to knocks. But actually, he'd taken plenty of time off work, so this hadn't been a problem for him. Indeed, when I saw Eric at the follow-up appointment, the wound was healing well. His note showed, however, that the sutures hadn't all fully dissolved after surgery, and that this had been a source of discomfort. Worried that perhaps there was an infection, he'd consulted a nurse, who'd removed them and also taken the opportunity to excise some excess scar tissue, which had formed at the site. I reassured him that this was by no means unusual and wasn't a cause for concern. I was pleased to see that when he returned for the final consultation, Eric's wound had generally healed well. As is the case with many Dupuytren's patients, however, Eric volunteered that, despite my careful explanation at our first consultation about the treatment and recuperation period, he'd entirely underestimated the impact of the surgery on his daily life and how long the disruption would continue. That said, his finger is now much straighter. This treatment for Dupuytren's never completely straightens the finger, nor restores full use, but he'd been aware of that from the outset and had no complaints on that score. So far, apart from the initial indications in his thumb, there is no sign of recurrence, although this is relatively common, especially over time. I reflected, however, that perhaps being very familiar with the condition and having performed this kind of surgery many times, I hadn't made it clear enough to Eric exactly what to expect after the surgery. What Eric's case made me realise is that I...